So Dr. Mix is going to talk about treating lung cancer without needing any surgery. He works up here in Oswego as well as at Upstate, and we've been doing stereotactic body radiosurgery, which he'll talk about in Oswego now for a few years. We actually have our newest linear accelerator radiation machine in our Oswego office. Mike.
Well, you won't forget who I am.
Get the right name up there.
That's right. So it really is a privilege for me to be here. Thanks for coming. I'm excited to be able to talk to you a little bit about something that I have a lot of interest in. So we're going to talk about 4D planning in stereotactic body radiotherapy for lung cancer. And if you don't know what any of those words mean, that's okay. By the end, maybe I'll help you understand a little bit, okay? We have some pictures and some videos that hopefully will make things clear. If I can figure out how to work this. Okay. So let's talk about what is SBRT. So SBRT is a long word, okay, and we'll break it down into little pieces. So stereotactic is a fancy word that means we're using three-dimensional planning, okay, and very accurately targeting the tumors we're going after. Body, of course, means we're treating the body, and radiation therapy is what it sounds like. So it's the use of high-energy X-rays that are very accurately targeting the tumor that we're after. Okay, so I'll hereafter refer to it as SBRT, but in case you ever hear anybody talk about SABR, S-A-B-R, that's an acronym that you might hear as well, okay? And so there are a few things that are important for SBRT. We need to use three-dimensional treatment planning, meaning we need to use CT scans and know how big the tumor is in all dimensions, okay, not just in 2 dimensions like we would see on an X-ray. Typically, SBRT is given in 5 treatments or less. Okay, we use large doses per treatment, and the radiation therapy is highly conformal, meaning it's very accurate, and I'll sort of show you what that means in a minute. Okay, and an important thing to keep in mind here is that when we use radiation therapy, our likelihood of controlling the tumor, meaning making sure the tumor doesn't continue to grow and in essence cured where it sits, is 95%. Okay, so this is a very, very effective therapy for patients who are correctly chosen for this treatment. So this is just sort of a schematic that shows you how SBRT differs compared to traditional radiation therapy. So in general, radiation therapy, historically was given Monday through Friday for up to 6 weeks. That would be sort of a typical regimen that we would use for lung cancer. And so as you can see, small doses of radiation week 1, week 2, all the way through week 6. Whereas SBRT is given in, for example, 3 large doses given over 2 weeks. So besides being a very effective therapy, SBRT actually also is something that is done a lot faster and ends up being a lot more convenient for the patient as well. So who are good candidates for SBRT? A lot of these patients are actually quite similar to the ones that Dr. Wallen described. Okay, so these are patients that have early lung cancer. So cancers that are small, haven't spread to the lymph nodes, generally stage 1 cancers, okay? And importantly, we most often are offering this therapy to patients who are not healthy enough to undergo surgery. So as Dr. Wallen alluded to, in a lot of situations, patients' lungs aren't healthy enough to afford or to be able to tolerate the amount of lung that needs to be removed for Dr. Wallen to do his surgery. And in those patients who aren't healthy enough or in whom the risk is too large, we oftentimes will offer SBRT as a very good alternative. We also have some patients who, despite our recommendations, just do not want to have surgery. And so some patients, instead of saying we're not going to treat you, we have this as a very good second option for them as well. Okay, and then in italic there, I say patients who are high risk for lobectomy or sublobar resection, which Dr. Wallen talked about. And that's sort of an area of controversy. But one of the things that we do at Upstate, as well as up in Oswego, is enroll patients on clinical trials to try to move the field of cancer management forward. And so, for example, at Upstate right now, we currently have a trial that's evaluating the role of SBRT compared to smaller lung surgeries in patients who maybe are somewhat high risk for surgeries. And so this is something that we offer our patients at the Cancer Center and up in Oswego consideration for. And finally, we sometimes use this technique in patients who have other cancers that have spread to the lung. So a breast cancer or a cancer from the bone or from the muscle. If it spreads to the lung and their cancer is otherwise well controlled, we will still consider surgery, but in some cases we can also use this technique to treat patients. And so I don't want to bore you too much with this, but if you look at the third column there, what this shows is that much of the evidence that's been published in the medical literature showing that the local control, meaning that our likelihood of curing the tumor where it sits in the lung is greater than 90% in most of the published series, okay? And we'll kind of breeze right through this. This is a similar table in patients who are operable, and this is a little bit more controversial, and this is the sort of thing that has prompted our investigation that I recently described regarding comparing the two techniques. So let's talk a little bit about what do we need in order to perform SBRT. So first of all, we need immobilization and reproducible positioning. So if we're going to develop a very accurate targeted radiation therapy plan, we need to make sure that the patient is holding still and we can put the patient in the exact same position each day for treatment. So this is an example of a patient in a customized mold that is keeping the patient holding very still, because if the patient moves while we deliver this sort of treatment, then our radiation may not be as accurate, and that should be fairly intuitive, right? So what's next? We need to precisely define the target. So we need to do something called a CT simulation. So that's a simulation of the patient to be treated in the position in which they'll ultimately receive the treatment. So the patient is sitting in one of those blue bags that I just showed you, holding very still, and we do a CAT scan. And that looks something like this, okay? So this looks like a patient getting a CAT scan. If anyone's ever had a CAT scan or an MRI before, maybe you can sort of understand what this position looks like. And our radiation planning starts with a scan that's somewhat similar to this. So these are images that actually come from that sort of a plan. So on the left, you see a CAT scan image showing a small tumor right here, okay? And on the right, we've started to outline not only the tumor, but some of the normal anatomy that's going to be important for us to avoid with the radiation, because ultimately our goal is to kill the tumor with radiation, but to avoid all of the normal tissue as much as possible. So these are just characteristic images of us working through that process, okay? So conformal or very accurate treatment planning. So this is a cartoon that I've developed that I'm going to show you a couple of times through the rest of the discussion. And if you can imagine, these are the lungs, and the red circle is meant to represent a tumor that I'm going to try to treat with SBRT, okay? So if we use just one beam of radiation to target the tumor, then everything in that beam of radiation is going to see radiation dose. So you can see that I may do my job in killing the tumor, but I may not be doing the best I can to avoid all of the rest of the normal tissue, right? But if I add a second beam, and a third beam, and a fourth beam, all from multiple angles, then only that one area where all of the beams overlap, only that one area sees the high radiation dose. And now I've come up with what we call a conformal, or a very accurate radiation plan. And this is something that's very important when we're using these high doses of radiation trying to cure these tumors. Okay. So this is sort of a three-dimensional picture from our planning system that kind of shows that. So you can see this is sort of a rendering of a patient in our planning system, and all of the yellow lines represent the different beam angles. And so this is a picture from an actual radiation treatment plan that was delivered with the intent of, again, achieving accuracy or conformality. Okay, this is another one showing beams coming from many different directions, and this is meant to be interpreted much like you would interpret a weather map. So the blue is cold or low dose radiation, and the red is hot or high dose radiation. And you see only the area in the center, and this is the same picture I showed you before, only the area in the center where the tumor has been drawn is seeing high dose radiation, and all of the rest of the beams or the rest of the body is seeing very low dose radiation. And again, this is our goal, to be able to deliver very high doses capable of killing the tumor right where it's located and avoiding the rest of the body with high dose radiation as much as possible. So this is a plan in which we were able to do this well. Okay. So next we have to, once we come up with a very accurate plan, we have to be able to know that the radiation is actually going where we think it's going. Okay, this is something we call image guidance. And so Dr. Bogart mentioned our linear accelerator, and this is a picture of our linear accelerator, the one that we have both at our Oswego clinic and down at the Cancer Center in upstate. Okay, and I'll orient you here a little bit. So this is the treatment couch where the patient would lay to have the radiation treatment. Okay, the top part here is called the gantry. It's where the radiation beam, the high energy x-rays actually come from. And finally, these two arms on the side, okay, are capable of creating x-ray images, even CAT scans if the whole thing moves. And so this is our way of double checking and making sure that the patient's in exactly the right position and everything is lined up just right before we deliver the radiation. Because if we work to come up with a very accurate radiation treatment plan and then the patient's not lined up right, okay, then a very accurate radiation plan becomes a not such good radiation, or a not so good radiation delivery. Okay? And so these are some of the tools that we use to make sure that this goes well. Okay, so this is an example of a CAT scan that comes from our treatment machine. Dr. Westphal would look at this and note that it's not of quite the crisp clarity that comes from the CT scans that they use, but it certainly serves the purpose to make sure that the tumor is located in the right position. Right? And so this is showing you that the CAT scan from our planning image and the CAT scan that was taken right before the radiation beam was turned on is lining up perfect. And the red crosshairs are crossing right through the tumor, showing that we know that the tumor is in exactly the right location before we turn on the radiation beam. And these, again, are all things that are essential to make sure that we deliver the radiation safely. So finally, I want to get to this idea of four-dimensional planning or respiratory motion. Okay, so let's go back to our simulation for a moment and take note of a couple things that are here. So this patient on her belly has a small cube, okay, that's going to move up and down as the patient breathes, and there's a camera right there on the end of the table that's going to pick up the motion of that block. And so what this is going to do, so as the block moves up and down as the patient breathes, the camera picks up the motion, and we end up with a respiratory tracing that looks like this, okay, up and down. And the idea is we're able to get a CAT scan, not just of a static image, but a CAT scan that shows us every phase of the patient's breathing cycle. So as you all likely would have guessed, our lungs move up and down when we breathe, the tumors move up and down in the lung when we breathe. And so we need to know if that's happening and be able to take that into account when we're delivering this type of radiation. Okay? And so this we call a four-dimension CT scan, or four-dimensional planning, where the fourth dimension is time. Okay? So this is an actual movie, and I'm very happy that it's working for you. So this is a CT scan of a patient, and you can see that almost everything's holding still except for the patient's lungs. So as the patient takes a deep breath and the diaphragm moves down, the lungs move with it, and the tumor, which you can probably all see here, is moving up and down. Okay, so these are the sorts of images that we acquire when we treat lung tumors to make sure that not only are we being accurate, but that we're not missing the tumor as it moves with our breathing. So let's go back to our radiation treatment plan for a second, right? So before, this looked pretty good. Our radiation dose was in light blue, and it was sort of focused right around our tumor, which is in red, okay? But if all of a sudden we realize that this tumor is moving, then you guys might recognize that we're not doing such a good job anymore, right? The tumor is moving out of the area of the radiation dose. And so we need to do something about this, or else we're gonna undertreat the tumor, okay? So one way we can do it is put a little pressure on the belly to try to make you not take such a deep breath. And sometimes that works. Okay, sometimes that works and we're able to just open up our field just a little bit to make sure we're encompassing the motion of the tumor. Okay, so in this situation, we're treating a little more lung with radiation, but we're still treating the tumor all the way through. But in certain instances, the compression on the belly isn't quite enough. Okay, the tumor still moves too much, and I think you would agree that if I had to open up my radiation treatment field any bigger, I'd be sacrificing too much healthy lung tissue, okay? And in someone who perhaps wasn't healthy enough to undergo surgery with Dr. Wallen because they couldn't spare to have their lung tissue removed, the last thing I want to do is treat too much lung with my high-dose radiation and cause a problem, okay? So what do we do about this? Well, we can go back to our radiation tracing, okay? And it turns out that when patients aren't breathing, the tumor holds nice and steady. That should be fairly obvious, right? But we can't ask patients to hold the breath for long periods of time. That's not a realistic request on our part. So what we're going to do instead is just find a stable portion of the breath. So it turns out that right when you're done breathing, before you go to take your next breath, there's a very stable phase in your breathing cycle, okay? And that's outlined there in these blue boxes. So these blue boxes are the area, correspond to the area in the breathing cycle where the tumor is going to be holding mostly steady, okay? And so what we're going to do is turn the radiation beam on just during that time frame, okay? And then when you take a deep breath and the tumor moves, we're going to turn the beam off. Right? So this is something called respiratory gating, meaning we're creating a gate within which we're going to use the radiation to treat the tumor, and when the tumor moves out of the area, we're going to turn the beam off, and we're not going to have lost much. Okay? So what might that look like? So you have to bear with me here because this is a manual animation. So the tumor's moving, okay, and as it comes back up into position, we're going to turn the beam on. And when it moves out, we're going to turn the beam off. Up, we're going to turn the beam back on again. Okay, and this is, right now it's me with the clicker, but our machines can do this automatically. So they can detect when this is happening, when the tumor's in the right position. And so here's a live image from a patient, okay, where this is actually happening. And so the red and blue circle corresponds to a radiation treatment field where we're trying to target that tumor that you can see moving up and down. And when it turns red, that means the radiation beam is on. Okay, so the tumor's being treated. When the diaphragm moves down because the patient's taking a breath, the tumor falls down and the radiation beam turns off and it turns blue. Everybody see that? Yeah.
How long is the beam on for?
It depends how long the patient's breathing. So some people breathe fast and some people breathe slow. So
I mean,
typically,
if you were to ask somebody to hold their breath, how long would they?
yeah, so that's a good question. Usually patients can hold the breath for 20 to 30 seconds, but we don't even ask them to hold their breaths. We actually ask them just to breathe normal, to breathe with a regular breathing pattern. And that same block that we put on the belly that I showed you goes on their belly during the treatment. And so we're monitoring that block the same way during the actual radiation treatment. And when the tumor's in the right position, we turn the beam on. Okay, and that's something that happens automatically. So how do we know that's working? Well, I don't know if this is going to project really well for you. Okay, but we actually have the capability of taking images while we're treating the tumor with the beam on. So we can see the tumor moving in the lung real time while we're delivering the radiation therapy. All right, so this is an image from our plan. Okay, the red outline represents the tumor that we want to treat, and that's in the lung. And on the right is an image taken from an actual treatment. So it may be a little hard for you to see, but I'll outline it for you. So that red line corresponds to this red line, and it's right where it should be. Okay, so we can actually monitor this in real time because we're doing something very complicated. And we want to make sure that everything's going right. And when we see the tumor right in that window, then we know we've achieved our goal and the tumor's there when it needs to be.
It's like science fiction. So is there a way to protect the tissues in between the radiation source and that tumor source? Or does everything get radiated at the same high intensity as you go through?
Yeah, so if you think back to my slide a little while ago where the beams were coming from many different angles, our way of doing that is by using multiple beams. So
They cancel each other out until you're at the point that you want them at?
right, so if we use 10 radiation beams and cross them only, where the tumor is, then only that area where all the beams are crossing gets the high lethal radiation dose. Everything else sees some radiation, yes, there's no way to avoid that, but it's a much lower dose, and in general, it's felt to be safe.
How long would a procedure like this take?
It can take anywhere between 10 minutes and an hour, depending on
And
how many.
people can hold still that long?
They do, but if they need to get up and take a break, we'll let them do that, and then we'll put them back on and re-image and get them set back up.
Are they given any sedative or anything?
Sometimes patients will take something if they need to, but the majority of our patients don't need it. Their arms are up, and our therapists work very hard to make sure that our patients are comfortable, and in positions that they're capable of holding for 30 to 40 minutes.
I don't know if I've ever held still that long.
Yeah, you'd be surprised. I'm sure you could do it. All right, and so just for completeness' sake, there's one final way that we can manage that respiratory motion. And so here you can see the tumor looks a little different, and that's because we've put a small marker in the tumor. So we put a small seed in the red tumor, okay? In this situation, we can actually use the radiation beam to follow the tumor as it moves up and down. okay? And this is something that we can do at one of our machines down at the Cancer Center as well. And I don't want to talk too much about this today. It's another option that's available for certain patients, but also equally impressive in terms of our ability to follow the tumor as it moves. So finally, all of these things that I've said require a vigorous quality assurance, and there's a whole team of people that work behind the scenes helping me and Dr. Bogart and Dr. Banishkevich do what we do. We certainly couldn't do it without them, so although I may have made it sound rather simple, there's obviously a lot that goes into it, and a lot of people working behind the scenes to help us. So thanks to Dr. Bogart and the coordinators for having me, and Dr. Kincaid for some of the slides that he provided. So happy to take any more questions if you have them.
What would be the side effects that is compared to just regular radiation?
So it's a good question. So the majority of patients don't have any side effects with this treatment, actually, okay? But the radiation can cause scar tissue in the lung, and that in certain situations can lead to more shortness of breath, or maybe cause a patient to have oxygen when they didn't need it before in rare circumstances. It can cause some fatigue. Sometimes people's shoulders get a little stiff from holding that position for quite some time. And then the rest of the side effects are somewhat specific to where it is. So if it's out in the middle of the lung, the only thing we're likely to damage is the lung tissue right around it, which I described. If it's closer to the ribs, we could potentially cause side effects with the ribs down the road. If it's closer to some of the other airways in the center of the chest, they're at risk. So it's very location dependent. Yeah.
Can you do multiple tumors?
We can, and we have done multiple tumors, yeah. So we can either do them sort of at the same time, or we can sort of get a patient through the treatment of one course, give them a break, and then do it again. This radiation is so focused, there's so little tissue, receiving the high dose that we're capable of not only doing two at once, but as Dr. Wallen said, we often have to continue watching patients because they are at risk for developing further tumors, and we can repeat the procedure in the future again if need be.
Is there the smallest size that you can do, or the largest size that would be
So we typically don't treat tumors that are larger than 5 centimeters. That's sort of our rough guideline, but it's just a guideline.
5 centimeters?
5 centimeters, yeah. So that's about that big. So we can treat tumors that get to be pretty large. Okay. Thank you for your attention.